Thank you, Natalie. Welcome everybody to this webinar. Thank you, Jill, for addressing the challenges. So taking things from there, my part will be covering what we have as evidence-based best practices for endoscopy processing. I know that it is too short to summarize all of these in such a small session for today, but those will serve as eye-openers for everybody joining us, and also an area for discussion if you have additional thoughts in that regard. So moving forward, talking about endoscopic procedures, we know that we have multiple potential sources of infection related to endoscopic procedures. Those could be of endogenous source coming from the patient's own flora, and we have exogenous sources, which include the pathogens associated with contaminated or inadequately reprocessed equipment or supplies. So while scopes represent a valuable diagnostic and therapeutic tool in the modern medicine, and the incidence of infection associated with the use of such scopes has been reported as low, we are having more healthcare associated outbreaks that are linked to contaminated scopes than any other medical device. So if you go through literature, you can check that over the past several years alone, there have been greater than 25 outbreaks of multi-drug resistant organisms, and mainly also including CREs in major hospitals in the US and around the world that have killed many patients and caused morbidity in hundreds more. So these outbreaks have been linked primarily to contaminated duodenoscopes that are used to diagnose and treat the diseases in the liver, the bile ducts, and the pancreas. And also GI endoscopes and bronchoscopes have been associated with far more outbreaks of infections, more than 130 outbreaks than any other reusable medical or surgical device in healthcare. And 9 of these outbreaks occur despite appropriate cleaning and high-level disinfection. So up to 8% of patients undergoing ERCP, which is a procedure in endoscopy, may develop an infection due to contaminated duodenoscope. And 42% of ERCP centers, which was studied in a Dutch study, reported at least one contaminated duodenoscope after reprocessing. So talking deeper about the causes of these failures in scope reprocessing, and as Jill addressed in the challenges, those causes are multifactorial and could include defective equipment, as we saw in the borescope image, inability to access the elevator channels during cleaning and disinfection processes, especially for the duodenoscope, inadequate cleaning and disinfection of endoscopes between patients, contaminated water rinses, contaminated automatic endoscope reprocessors, biofilm generation in endoscopes or AERs, inadequate cleaning and disinfection and sterilization of endoscope accessories, in addition to contaminated multi-dose vials, needles, syringes, or other items used during anesthesia or patient care. So prevention and control of infections associated with endoscopy depend on multiple factors, including the education, the training, and the skill of the practitioner, the integration of the device, ensuring that the equipment at first stage is free from defects, in addition to strict adherence to reprocessing protocols. And evidence-based practices are essential to be followed, and those would include updated practice-specific recommendations related to endoscope use. And we have references for those from international organizations like AURN, AMI, APIC, and SHE, in addition to education, which comes as a major element. So everyone involved in the reprocessing of the flexible endoscopes should be knowledgeable of the current issues, the challenges which are faced in endoscopy, including also the most recent instructions for use, the IFUs, and regulatory protocols and the information and the policies and procedures in the endoscopy suites. So let's talk first about the endoscopy environment. So creating a safe environment includes adherence to the infection prevention standards and the regulatory requirements and following practice-specific evidence-based guidelines. So coming to the physical design, it's an essential element in addition to the workflow of the endoscopy area, which should reduce the risk of cross-contamination and provide a safe environment. Endoscopy personnel are at risk of exposure to patient-generated infectious material through splashes or other contaminants in the environment, in addition to chemical exposure. So it is critical that the proper personal protective equipment shall be available and used in the proper manner. So what about the parameters for the endoscopy unit in terms of design? So each area within the endoscopy unit should have a designated flow for the safe physical movement of dirty scopes that do not cross-contaminate with the clean scopes, which will come out of the cleaning process and will go to the storage area. This table represents the design parameters, and as you can see, we need to be ensuring in the reprocessing area we have negative pressure. The minimum air changes per hour should be 10. In addition to the procedure room, there is no requirement to have negative pressure, it's equal pressure. And a bronchoscopy procedure room where it's considered as an airborne isolation room should have negative pressure with 12 air changes per hour. So in addition to that, in the reprocessing area, we must have adequate space for reprocessing. Jill mentioned about the enough space to have additional sink if we need to have extended soaking. So this is important to address the adequate space, the appropriate airflow and ventilation from selection and the method of the disinfection and the chemical sterilant that is used, and appropriate storage area, which follows the proper workflow. Reprocessing areas should be accessible only to authorized personnel. The workflow should be unidirectional. So we mean by that movement from the dirty to the clean area in order to minimize the opportunity for cross-contamination. And the dirty and clean areas should be physically separated from one another. And when reprocessing occurs in two rooms, the decontamination room should have negative airflow, and the temperature, in addition to the humidity levels, should be in compliance with the local and facility requirements. So the following are key elements to consider in the endoscopy environment. For sure, food and drinks should be prohibited from both patient care areas and the medical device reprocessing areas. Heating, ventilation, and air conditioning should, in the endoscopy, should be in compliance with the regulatory agencies and local building codes and the policies and procedure and the accreditation standards. In addition, patient care areas, procedure rooms, and operating rooms must be cleaned and disinfected after each patient. And when a procedure room or the patient care area is in use, it should be terminally cleaned at the end of the day. And there should be schedule for routine cleaning for the areas that are not terminally cleaned, and should be this determined through the policy that you have in your suite. With the exception of the point of use cleaning, reprocessing of contaminated equipment should be performed in a separate area or room, not in the endoscopy procedure room. Now, talking more about the environment, let's address the water issue. So water hardness is an important element we need to be aware about. So hard water used in final rinse in the AER cycle may cause deposits on the endoscope. And these deposits will act as potential focus for soiling and decontamination of the endoscope. And it may also seriously affect the optical system of the endoscope. Temperature is important of the water. So too high temperature during initial flushing stage may lead to the coagulation of the proteins, and they cause the fixation of the protein soiling on the surface of the endoscope. So you need to be referring to the manufacturer instructions for use. to select the optimal temperature to be set that is required for the detergent and disinfectant that is used. In addition to that, the chloride concentration, so water that is used in cleaning and disinfection of the flexible endoscopes should have a chloride concentration between 0 and 120 milligram per liter to avoid the risk of corrosion on steel and plastic components of the endoscope. And lastly, the microbial contamination. So the water supply that is coming to the endoscopy, especially to the AR, should be treated using filtration and should be RO water in that manner. Now, in the following slides, I'll be addressing in a quick way the general steps for endoscope reprocessing. As you know, proper reprocessing is essential to prevent healthcare-associated infections. And the complexity of the reprocessing involves pre-cleaning, cleaning, disinfection, sterilization, drying, and storage. So all these are considered complex milestones in order to end up with a safe to use and disinfected scope. So starting with the pre-cleaning, this must be done in the procedure room immediately after the removal of the insertion tube from the patient and prior to disconnecting the endoscope from the power source. It should be performed at the point of use before bioburden has an opportunity to dry and before complete decontamination using the enzymatic detergent. So pre-cleaning of each device should be based on the IFUs. Keep this in mind. Leak testing is the next step. It should be performed after each use and before use of a new, repaired, or a loaned endoscope. Leak testing must be done in accordance with the endoscope and leak testing equipment IFUs. If it is done in the automated method or the manual method. So what happens if you have leak testing failure? So you need to remove it from service and send for repair or replacement. You should not proceed to reprocess it as it might damage the scope. And you should be careful to prevent environmental contamination during the handling and transportation of the scope after failing the leak test. So what about the manual cleaning? It is an essential practice before the before the automated disinfection or the manual one. It is the most important step in removing the microbial bioburden from the endoscope because failing to do that, it will cause failures in disinfection or sterilization in that manner. So IFUs should be followed. The proper time frame for reprocessing must also be respected. If there is a delay in the reprocessing, also you need to be applying the IFUs in that manner. And the area where the manual cleaning of the scopes occurs must have the optimal lighting and magnification and additional aiding tools to ensure that the lumens and all the surfaces of the scope are being checked properly. So in that process, in the manual cleaning, the sink that is designated for scope cleaning is filled with the detergent that is compatible with the endoscope as per the IFUs. You should disconnect and disassemble endoscope components like the suction valves as far as possible and completely immerse the scope and the components in the detergent. And definitely IFUs should be followed for the proper dilution, the temperature, and the contact time. And in that manner, the scope should be meticulously cleaned with the entire endoscope having its accessories, the valves, the channels, the connectors, and all the detachable parts according to the IFUs using specific and convenient brushes and items for cleaning. So the next step would be the high-level disinfection. It is achieved either manually or through the automated endoscopy processor. So AERs provide a superior cleaning and decontamination, improving the rinsing of disinfectants and reducing residual disinfectants in the endoscope as compared to the manual process. High-level disinfection is the recognized minimal standards for semi-critical flexible endoscopes according to the Spalding classification. So at some instances, sterilization of endoscopes may be indicated, and this happens when the endoscopes are used in a manner that meets the definition of critical medical devices, like getting into a sterile field with potential contamination. At that instant, the endoscopes should be considered for sterilization. Keep in mind that the endoscopes are heat sensitive and cannot withstand steam sterilization. Therefore, they must be sterilized using low temperature methods, for example, ethylene oxide or hydrogen peroxide or ozone sterilization as a mean for terminal or for sterilization. And this should be validated as per the IFUs. And the scope and its accessories should be cleaned and dried per manufacturer's IFUs before the sterilization. And it is important to ensure that the moisture has been removed prior to sterilization, because presence of such moisture in the lumens may interfere with the sterilization process. So next comes the drying and storage. Those constitute the final steps in the reprocessing. So drying greatly reduces the possibility of recontamination of the endoscope by waterborne microorganisms. Drying must be performed even if AR has a purge or a drying cycle. You need to conduct a risk assessment to ensure or decide if alcohol to be used after that cycle. You need to be ensuring that all adapters are removed. You need to dry the exterior of the endoscope with a soft, clean, lint-free towel, and dry accessible endoscope channels with a pressure-regulated instrument or pressurized air as per the IFUs. Do not attach removable parts during storage, and ensure that the endoscope should be dried after every processing cycle, whether the intention is to store the endoscope or to reuse it immediately. And keep in mind that endoscopes must be stored in a secure area, not in the procedure room. And this area should be clean, well ventilated, and dust-free. And the way that you store your scope will protect them from recontamination. So if you are following the conventional drying storage or the cabinets, you need to be ensuring that storage or drying is done properly in that manner. Drying cabinets have been shown to reduce the risk of microbial contamination, so they are the best practice to be applied. Drying cabinets provide a controlled environment to help ensure that the endoscope channels remain dry. And if a drying cabinet is not available, the storage cabinet should have HEPA filtered air to allow circulation around the flexible endoscopes, and the flexible scopes must be dried prior to storage, as I mentioned. So endoscopes definitely should not be stored in shipment or containers or cases. So now, after this stage, you need to be transporting your endoscope. Transportation tools or boxes should be clean, closed containers that are non-porous, puncture resistant, leak-proof, and large enough to allow the endoscope to be coiled without damaging it. And if the transportation container is reusable, it must be cleaned and for clean scopes. Single-use containers So here are some supplemental ensuring that we have proper reprocessing of our scopes. So, and this will include, I still have a few more slides in that manner, and I will be done. So this will include the routine microbiological surveillance for endoscope, periodic sampling and culturing to detect contamination, and protocols how to respond once you have positive cultures identified. So this table gives you an overview of the current processing quality control measures, which will include the ATP test, that tests for organic residues, the boroscope inspection, and the culture method. And each one has its pros and cons and indications when it is done. So in addition to that, we have enhanced the cleaning protocols for the endoscopy environment. And for the scopes during drying technique in that manner using forced air. In addition to use of disposable accessories, definitely use single-use items. There are also trends now to use single-use endoscopes for specific procedures. This has benefits, and in addition to that, challenges. And an important element as a major helpful method to ensure that we have proper staff training and ensuring they are competent enough to handle the scopes and do the reprocessing protocols. The competency assessment should be assessed regularly, and your staff should be up to date with the guidelines and the proper practices for endoscope reprocessing. And by this, I reach the end of my presentation. Thank you all, and over to you, Natalie.